Thank you very much, Dr. Prashant and Dr. Padmaj Safalta, my friends, for inviting me for this talk in the first perceptorship program. So I think the task assigned to me by the team is to speak on staging and prognosis of lymphoma. Trust me, all of you do it daily. So I'm not here to teach you how to stage a lymphoma and prognosis, but let us agree that there are nuances and subtleties involved with staging on daily basis. No matter how much you read, you will always find one or two things which are kind of missing. Thanks. In the course of my presentation, I will try to touch upon those subtle points and let us learn together during this process. These are my contact details, and I would suggest that rather than taking photograph, you just focus and discuss the topic among ourselves and with me, with all the faculty member. And I promise you, I can email all the slide deck to you, and you can just read them again at in the comfort of your home. Right. So let's start with what defines staging. What is the purpose of staging? There are 2 points. So when we speak about defines staging, simple. Any process of knowing disease location and its extent, prognostic information, a tool to provide baseline against which we can compare the future response, and comparison amongst trials, various kind of study. Very simple, but this is not the purpose of staging. The purpose is we want to ensure that we are not under or over treating any patient. So this is where our focus has to be. Right. So now from staging in general in oncology, this is generally applicable to tumors. From this, we are going to move to specifically lymphoma. How do we use it? We use the staging to define what will be the number and intensity of the chemotherapy cycle. We also use it whether we want to give RT or not. If we want to give RT, what kind, what dose. Third is whether there is a need of transplant. Although staging is not a very strong for that, but it is used. There are escalation and de-escalation strategies, and we know staging plays a role in that. And lastly, we will see during the course of this presentation later, in calculation of various scores like IPI and IPS, staging is an integral part of it as a very important variable. Right, so let's embark upon the journey. It is very interesting story how staging systems in lymphoma evolved over last half a century or maybe more. The story started from this Peters three-part system, 1950. Before that, it is only, lymphosarcoma of intestine of the movie Anand or something like that. No staging was there. First time it was put in by Dr. Peters in a paper. He was a radiation oncologist. And at that time, lymphoma used to be classified into 3 stages, 1, 2, 3. It was very basic. We will discuss it. The watershed movement in staging of lymphoma came in 1970. Staging system, which all of us still use. After that, fast forward 2017, when we have PET CT, which is functional imaging. And this is now universally available to all of us. So when the harmonization project was kind of talk of the town and it produced its results, so it is. And after that, I think the arrow is misplaced, and this is for Lugano classification, which is the paper, the seminal paper by Bruce D. Chesson, and all of us should be studying this paper almost on a regular basis, should be revising it. Okay, taking you back in time, 1950, Peters three-part. This was an era when clinicians have their hands, maybe stethoscope or maybe some X-rays. So in this era, whatever staging was possible because of these 2 or 3 tools. As a result, the staging was limited to very, very gross and basic things. The paper was published in 1950, and this is a study of survival lymphoma treated radiologically, meaning thereby treated with radiotherapy. That was the era of nitrogen mustard, the only drug for lymphoma, and radiotherapy, almost mental field radiotherapy, inverted Y shape radiotherapy used to have its limitations. So they were classified into 3 stages, and try to look a lot to find the original paper. But somehow this paper is missing from the archives. So what we know of this, that was the first instance in the history of mankind when the staging system was used for lymphoma. Then came 1966, which is Rye staging system. This was the first time when the current in this photograph, you can see all of us are familiar. This kind of staging was proposed. However, there were certain differences, and this is just a paper in 1966. Right. So 2 and 3 are largely what we see today. I would like to draw your attention to stage 4. This is interesting. Please believe this is an era of pre-functional imaging, pre-CT scan was available. At that time, any involvement of extranodal site, read here, bone marrow, lung, liver, bone, skin, kidney, GIT, or any other tissue or organ in addition to lymph node used to be labeled as stage 4. So stage 1, 2, 3 is nodal, one side, two side of diaphragm, almost similar, identical to what we do today. Stage 4 is any extranodal site, whether contiguous or non-contiguous, to be called taken as stage 4 disease. It is almost taken to what we do for solid tumor. Breast cancer went to bone, stage 4 straight away, even if there is a single lesion. So almost similar on similar lines. This classification, RISE classification was there. But the structure, the model of this staging system is still persisting. B symptoms, which is always interesting. This was the first time the concept B symptoms was introduced for lymphoma. The original 3 B symptoms were fever, night sweats, and pruritus. We will agree that most non-Hodgkin is learning from Hodgkin. Whether you call off these kind of classification or prognostication, or you speak of dual score, dual it for Hodgkin, and now we left and right use it for NHL as well. So the first 3 B symptoms were fever, night sweats, and pruritus. And in this paper, I think they have noted that other symptoms, like all these 7, 8 symptoms, are very important, but they found, because of multivariate or univariate analysis, that they were not sufficient enough in themselves to be called as a prognostic marker. If you read these symptoms, weight loss, malaise, weakness, fatigue, anemia, leukocytosis, leukopenia, lymphopenia, elevated ESR, energy, and alcohol pain. Now, if you see the highlighted section, all of these are various prognostic scores. We have IPS which is Hassan-Clever index. And you can see the weight loss. Weight loss is a part of B symptom. Anemia, leukocytosis, lymphopenia, all is part of the IPS, and ESR is used for prognostication of Hodgkin almost in all stages, especially early stages. Now comes after 66, within 5 years came the Ann Arbor. Now I would like you to take a pause and marvel at the fact that this happened half a century ago, and we are still using a system, same which was developed in 1971. That was a foresightedness of people working at that time, because a little has changed. Only subtleties has changed, which we are going to discuss anyway. So Ann Arbor is a small town near Detroit in the US. I was always, we always think, I always used to think Dr. Ann and Dr. Arbor are somewhere and they developed this thing, and so very much nice, but then it is not it is the place. And I think it's a good way. When you take names and all, so it is always, there is some kind of issues, right? Who is the main contributor, whose name should be here and there? We all grapple with that. It is a good thing to have a name, to name something, the classification or staging system according to the place where it was done, Ann Arbor. So this is where it is. This is the report which is published. So what changed? So they retained the four part or 4-stage classification. Now, in RISE classification, B symptoms were introduced. In Ann Arbor, subscript E, which is for extranodal site, and it is given for any contiguous involvement of nodal disease, extranodal organ, which could be encompassed within one irradiation field. I think it remains unchanged till today, and this was a major addition in the Ann Arbor meeting classification. The second thing is, which is now obsolete today, is pathological staging. This heralded era of staging laparotomy. Before that, in 1960s and 70s, barely USG were there. CT scan was not heard of. They just used to palpate and the spleen was enlarged. It was called as spleen is involved. But now they started speaking that you do staging laparotomy, you do splenectomy complete, take piece of liver, and do multiple lymph node biopsies in order to stage any patient of lymphoma optimally. When they started doing it, they put in 2 words like CS and PS. CS means clinically staged, meaning thereby you have done clinical examination, laparotomy was not done. PS is pathologically staged lymphoma. You have done laparotomy, liver, spleen, and intra-abdominal lymph node, and you have ensured that there is no intra-abdominal disease. We are dealing with early stage. So I think if you want to remember, introduction of extranodal site and staging laparotomy was introduced in Ann Arbor, which is now completely obsolete. Everything else remains almost unchanged till today. Now comes the second thing, which is modification of Ann Arbor staging, which is Cotswold modification. Ann Arbor remained there for around 20 years, and this meeting was held in UK in this beautiful town. If you see, this is the current photograph of Cotswold, and you can see time English town. The buildings are away from modernity, except these kind of cars and all. This is a very, very scenic place, and I think any lymphoma enthusiast should visit this site. I dream to. Now, what was done in this modification? After 20 years of Ann Arbor staging, CT scan was introduced. So after we are talking of almost coming to the current era when we were born, CT scan was included. Staging laparotomy was, completely taken away. The second thing is criteria was developed for allocation of splenic and liver involvement. Something which remains unclear to me is this point. It is written in this paper that to declare splenic or liver involvement with lymphoma, it was needed to have evidence of focal defects with 2 imaging techniques. Other seniors and other colleagues can kind of put upon this why 2 imaging techniques were needed, but this is a part of the paper. And one thing this modification did is initially people used to think if in a patient with lymphoma liver functions are deranged, it is because of lymphoma, and they used to consider it as a liver involvement, stage 4. But this classification excluded liver function abnormality as a staging marker because they started using CT scan. They could see the entire liver easily. Now, third thing they introduce is suffix X. So if I summarize, in Rice classification, B symptoms were introduced. In Ann Arbor, extranodal disease was introduced. And in Cotswold modification, they introduced X, which is bulky disease. And all of us know for Hodgkin, it is 10 centimeter. And now for non-Hodgkin, we are going to discuss, it is more than 7.5 centimeter. One more thing, which is, which I learned as a part of preparing this talk is CRU. I always thought that CRU is a very recent thing, in the PET era thing, because when we see something is Duvel 3, we call it CRU. But CRU is old. If you see in 1989, they introduced CRU and they said, after doing treatment and when they do CT scan, there is some shadow and they are unsure. The radiologists used to be unsure whether it is a residual lymphoma, residual fibrosis or something else. They started calling CRU. Right. So this is a historical thing. It was fascinating. And now coming to the current PET-CT era, and PET-CT is a sophisticated machine. It has made our lives very, very easy. Now, it was included in 2007. Again, Bruce D. Chesson, who is a very prolific lymphoma doctor, he spearheaded introduction of PET-CT scan lymphoma in a big way. So after involving PET-CT scan, small changes which were also made. Kunal spoke about bone marrow role of flow in lymphoma. So bone marrow immunohistochemistry and flow cytometry was included as a part of doing staging, proper staging of lymphoma. Previously, you do a bone marrow. If you are seeing malignant cell, it is lymphoma. Otherwise, it is not involved by lymphoma. But now they say that you have, if you want to do an optimal staging, you have to do ISC on all sections, even if there is no visible lymphoma cell or malignant cell over there. And as you know, they have to change something. They eliminated CRU because said now since we are incorporating PET-CT, which is a functional imaging, we now clearly know whether it is disease or not. So therefore, they wanted to take away CRU. Now let us discuss. This is always a debate between PET and CT scan. Most of you are much younger than me, and you are all your PET generation. You have probably not seen the era of difficulties of getting CT scan per se. But I agree, PET is good, definitely good. Why? It improves the accuracy of your staging. PET can lead to change in stage up to 10 to 30%, which is a big number. And mostly it is up staging. So therefore, it is ensuring that you are not under treating a clearly PET advantage. And it is a better modality to detect extranodal sites. Let's take an example. Now, this is a gentleman who presented with multiple cough and other symptoms of lymphoma, and you can make out mediastinal lymph nodes are there. This is a large para-aortic lymph node in the chest cavity, and these are hilar lymph node on both sides, and some other lymph nodes in the hilar bilaterally equal symmetrical. And if you see lung cavity by and large is normal, except some haziness in both bases, if it is visible from the back. So it looks clearly a nodal kind of lymphoma, and you would say no other issue in CT scan. Now, when functional imaging was done in this case, so apart from these very deeply lit up lymph nodes, you can see there is a large pleural and lung involvement near the vertebra paraspinal mass over here. So clearly a plain CT scan would have missed it. So therefore, this is the beauty of doing a functional imaging up extranodal site in a better way, apart from upstaging of disease in 10 to 33% of 30% of the patients. Now, this is a paper they studied on a same data set accuracy of predicting various sites using either a CT scan or a PET CT. It might be looking a lot, but let us just focus on accuracy part. For lymph node, you can see the accuracy of CT is very decent, 90%. But for the accuracy of PET CT for lymph node is 98, very high. If you talk of spleen, this is where the difference is, because spleen, you will find slightly increase, say 10 centimeter spleen on CT, sure whether lymphoma is there or not. So therefore, accuracy is 76%. Here it is 99%. Huge change. Speak of bone marrow. Again, the accuracy is 75. This has been a pain point for most lymphoma doctor, for that matter, for most hemato-oncologists. And here you see accuracy, it is 99%. Where I do not believe 99, but it is very high. Now, have a look at the extranodal involvement by CT scan. There, it is written accuracy 95%, should be much below that, but almost 99.500% accuracy in predicting extranodal involvement. So total, you can see accuracy of PET CT of normal CT scan, CT scan is 88%, and % is for PET CT. This is, please believe, this is on same data set. So therefore, this comparison is much more valid. So if I can conclude that for aggressive lymphoma like DLBCL, cellular lymphoma like Hodgkin, Mendel cell, and aggressive TNHL, PET CT is now clearly accepted modality of staging, and it is definitely better. The problem occurs with indolent NHL, and indolent, when I speak of indolent, small cell lymphoma like SLL, CLL, lymphoplasmacytic lymphoma, Waldenstrom, mycosis cutaneous, and marginal zone lymphoma of various varieties. Here the problem is superiority of PET CT is not established over CT scan, because the growth fraction, the dividing cell which eats up most FDG, are not very high in these small low-grade lymphoma. So therefore, advantage of PET CT for indolent lymphoma is only when you are suspecting a high-grade transformation, or you are suspecting atypical site of involvement of extranodal lymphoma, say for example orbit, and this mass is active or inactive. So these are kind of a bespoke decision whether you want to do a PET CT in indolent lymphoma. The other area of concern for PET CT is involvement, to pick up involvement of GI system by lymphoma. Now, please, those who work in medical oncology, please go back to your colon carcinoma patients. You will see in PET physiological uptake in the entire gut and colon, because it is always in the process of peristalsis. So therefore, the same impact is there in patient of lymphoma also, whether the uptake is because of physiological activity, some inflammation. GI is very immunologically active, inflammation is there, or is it per se because of lymphoma? This is one area where PET CT is not very, very robust, and therefore it is recommended in the paper that other investigation are suggested if there is a doubt. And the other investigation that I can think of very easily is endoscopic confirmation of involvement of GIT by lymphoma. For other extranodal site, PET CT is the best modality. Now, let us discuss. I think any point of discussion till now, Prashant, Dr. Padmaj, I think we should be more interactive, and other faculty members.
Any question from any of the preceptees or any
regarding
faculty
PET CT?
regarding utility of PET CT or the staging system?
Sir, Dr. Prabhas, sir. Yes, sir. I actually agree with that, because if you see in this list, I have not follicular lymphoma. The reason is because follicular lymphoma, thankfully, is largely a nodal limited. And for assessment of node, PET-CT is a very good strategy. So this is a very nice point made that follicular lymphoma is somewhere in between. I am very much comfortable if I am having a CT scan in a patient with follicular lymphoma also. But if you, for example, I'm going to discuss that point now. In these three settings, let's be realistic. Let's see day-to-day work. Now, all of us might work in three kind of settings. Number one, where PET facility has a long waiting list. Example, AIMS PJ Chandigarh, where I work. There is a large academic centers, and sometimes our waiting, the routine waiting go up to 3 months to 4 months, sometimes 6 months also. Second is PET-CT is disproportionately expensive, especially this kind of situation is maybe there. I mean, cost is always a touchy issue, but then in private sector, definitely the cost of doing a PET-CT is quite high. And third is PET-CT is not available. Now, why go far away? So I work in Chandigarh. We go to just Shimla. Shimla is a district headquarter. They have IGMC Shimla. PET-CT is not there. Does that mean they should not treat lymphoma? Or does that mean if they are treating lymphoma on the basis of CT scan, it is suboptimal? So answer is, we have to be practical and pragmatic. In all of these three settings, doing a CT, neck, chest, and abdomen is an absolutely acceptable and correct staging procedure for any subtype of lymphoma. However, when these limitations are not available and you have options of choosing both, then with a reasonable amount of certainty, all of us can agree that PET-CT, at least for aggressive lymphoma and follicular lymphoma, can be a better modality. So thoughts and discussion on this.
I think for follicular lymphoma, I agree that PET-CT is important because I think with the POD24 being one of the criteria, PET-CMR at end of treatment is also a prognostic factor, a significant prognostic factor in follicular lymphoma, and patients who have not achieved that they're at high risk of progression and aggressive behavior.
Right. Participants, questions, queries, or maybe I have examples.
Yeah, please.
We will. Yeah.
Sir, on basis of PET FDG activity, can we differentiate between or have a guess it is follicular or high grade lymphoma like DLBCL? If acid is more or less.
Yeah. So as I told you, the one role of doing PET-CT in indolent lymphoma is when you are suspecting a transformation. The clue, the radiological clue of transformation are there, but then pre-test probability, the concept of pre-test probability. You would order a PET-CT when you are suspecting. When would you suspect high-grade transformation? A patient of say follicular lymphoma or SLL came to you with, sir, I am having fever, aana shuru ho gaya, I am losing weight and I was doing well till now for last 1 month. You are suspecting. You have seen that lymph node has increased in size. So when you do imaging and you find that there is a disproportionate uptake in a region, in comparison to the other lymph node site, because transformation happens in only one cell, only one clone, then it proliferates and takes over all indolent cells. So if you find something like this, where one dominant lesion is there, where FDG is disproportionately high, then you can probably say that with a high pretest probability of transformation in this given patient, this represents transformation. However, if you say generalized, whether is there, if I take your question in a different manner, you are asking, is there any cutoff below which we can say we are having indolent lymphoma and above which we are saying it is aggressive? So that cutoff has a very, very sensitivity. Some people, we always try to comfort ourselves, okay, 10 is that cutoff. Some people will argue against it. So I'll just say, do not go by that. Let's trust our pathologist after, and they will tell us whether it is low or high grade tumor. Any other discussions? Yeah.
So would you think that after doing PET-CT, is there any rationale or need of doing bone marrow aspiration batch?
We will discuss that. That's a part of discussion. Yeah, thank you. Sir.
System imaging staging. Any specific, because CT and PET-CT both have their own limitations. So what's the role of MRI in that situation? Has it been formally included?
Right, sir. So what happens? So this question is about primary CNS lymphoma. In practice, invariably, primary CNS lymphoma will come to us from neurology, and they would have a PET MRI with them. In fact, contrast MRI and everything will be ready, and CSF will times, and they will say it's demyelination. We have given methylprednisolone, and do something. So the globally by the International Extranodal Lymphoma Study Group, it is well accepted that the investigation of choice to rule out systemic disease in primary CNS lymphoma is PET-CT. because all primary CNS, not all, 99% CNS lymphoma, DLBCL of aggressive B cell variety, and they are very prolific, very highly PET avid. So if somebody is having involvement of systemic site, PET CT will pick it, because CT scan doing and one lymph node, you will always be confused. So if you are having a primary CNS lymphoma refer to you from neurology and you want to rule out systemic, PET CT is a way to go. I think this is one situation where you should even refer the patient to a centers where PET CT is available. I told you that in centers PET CT is not there. Let's use with the stage with CECT, but certain instances like this you have, because treatment is completely different. Primary CNS lymphoma approach is CNS directed high dose, but if you are dealing with a systemic lymphoma, then why to subject the patient to kind of toxicity which is involved with high dose therapy and brain radiation? So this is some very
Lingaraj
point raised.
Yeah, so there is a situation where you get no occult transformation, right? You told about pretest probability. So suppose there is no clinical patient transformation.
Right.
In PET, you get this area where you get a disproportionate SUV
Right.
and you can't biopsy it.
Right.
And that's called like a occult transformation. So what do you do in that?
So we would never know an occult transformation. So like it's like again the same thing, the story of doing PET CT every 6 months. We all understand there is no evidence to support that. But to be honest, we have seen patient coming with 6 or 7 or 8 PET CT that we wanted to see whether ये वापस तो नहीं आ रहा है, तो हमारा ठीक है, we are happy. Same thing. So occult transformation, if it happens, it will manifest. Transformation is only a matter of time. Now, if some of us did anticipate and found one transformation 1 month early, probably is too much. I mean, it will not work. So, sir.
PET for intravascular lymphomas.
Intravascular lymphoma, sir.
Yeah.
So intravascular lymphoma, especially of the CNS variety, are PET avid. So they are tumor, and what happens, they start intravascularly, but then invariably they invade all other visceral organ. Luckily, in PGI we have CPC, and last time we have seen one autopsy where lymphoma cells were invading all solid tumors. You name it: kidney, liver, lungs. Liver and spleen are fine, but lungs, myocardium, kidney, every cells were infiltrating and they were cuffing around the vessels. So PET is very aggressive, but then you can't say it is intravascular on PET CT. It will just show you a completely overhauling of all the tissues with the lymphoma cells. You have to have a biopsy and demonstrate it is intravascular, kind of rosetting it is shown. Right. So I think let's move on to the latest, the article which I like and almost keep reading whenever I get time, which is this article published in JCO 2014, and whatever name you are reading here are who is who for lymphoma, especially in the North American side. This is mainly more American dominated paper. And this was again, a product of this meeting, which is at Lugano. So by now you will be just, wondering that somehow lymphoma doctors have some good aesthetic sense of choosing places. And it makes a point to go into lymphoma because you may get to travel to these beautiful places, Cotswold, Lugano, and one more is Pan Pacific meeting in Hawaii they have. So these are 3 lymphoma focused meeting. So this is a beautiful, again, a lakeside, a very small town. You would wonder why they are keeping meeting here. But the meeting was held in 2011, but the paper came in 2014. Now, from this lighter moment, let's come to the main changes which were made. So coming to now, this is the, this is the structure of a lymphoma staging system. These are the components. These are 4 suffix, and this is the staging part. When we talk of staging from 1966 or 71 Ann Arbor, nothing much has changed. This diagram only changes the colors. Everything else remains same. You all are aware, just briefly, one side of diaphragm, one lesion or one group of lesions, 2 which are away from each other, both side of diaphragm, and different multiple side. We will discuss stage 4 in a detailed manner. Right. So stage 4, as per the current 2014 Lugano understanding, is involvement of liver, bone marrow, brain or CSF in a patient with systemic lymphoma, multifocal non-contiguous lesions in lung. We will see an example, and multi-organ extranodal sites. Now, this is something which can always be subjective. This is something which is slightly, we will see with examples, but This is what is accepted definition of stage 4. Now let's take this example, a case study. Middle-aged woman, she noted a lump in her breast, went to a surgeon and who palpated that there was clearly a lump, thought of a breast cancer or something, ordered FNAC and a PET scan simultaneously. And this is what turned out to be. You can see in her right breast, there is a large lump, a cellular homogeneous lump, red arrow. It is destroying the underlying rib. It is reaching up to the pleura. Maybe you may call it some infiltration into the liver. Maybe some mediastinal pre or pericardiac lymph node might be involved, or internal memory group of lymph node are exactly here. Now, what stage will we call it? How many of us will agree with stage 1? Raise of hand. Just make it interactive, is not your exam. Okay. Stage 2. We have more and more agree. Stage 3. Nobody. And stage 4. So I think stage 4 wins probably. But now let's apply, this teaching in verbatim. I think let's remove the emotion part. There is one lesion which started somewhere here, maybe in an internal memory or pericardiac lymph node, maybe in the chest wall. And from here, it is just growing contiguously and eating up the tissue, whichever is coming in its way. On an inner side, it is pleura or maybe lung, or outside is the breast tissue and subcutaneous tissue and the bone to some extent. So it may still be called as primary extranodal lymphoma of the chest wall. Now it depends which group do you belong to. If you are an extranodal enthusiast, you will call it is primary extranodal lymphoma. But if somebody say it is more advanced and disseminated, probably it is a soft point, debatable, and this is a gray area of lymphoma staging, which is extranodal site involvement. Luckily, to our rescue, there are other images for this patient. On a detailed PET CT, there was a discordant, same pleural and lung lesion. There was a large bone marrow focal, very, very avid lesion, and maybe some deposit, or I'm not sure, but although it's not avid, maybe something here and there. So now it becomes a stage 4 clearly. But as far as it was here, it was localized extranodal lymphoma. As my privilege to being a speaker here, if you want my opinion, I consider it to be stage 1E with multiple extranodal site at one location. Please come ahead if you have any thoughts and suggestions. It is an open discussion. The second patient is, again, somebody 60-year-old male who presented with pain and fever. So pain in abdomen and fever, somebody ordered CT scan, and then corresponding PET CT images are also available to us. You can see this is right kidney, this is left kidney, disproportionately enlarged, complete abrogation of corticomedullary differentiation. It is cellular, almost nothing is visible except the infiltrated tumor. There is some lymph node also, a small lymph node over here. And PET CT is clearly showing very, very high FDG uptake in the kidney itself and in the pelvis, or I'm not sure whether it is pelvis or a lymph node. So it is over here. This patient is definitely primary renal lymphoma, we may call it at this juncture. But if we involve other imaging sites, this patient had multiple mediastinal lymph node. You can see subcarinal lymph node is over here, para-aortic, para-caval lymph node is over here, and there is again parabronchial lymph node, hilar lymph nodes are here. This patient has a rib lesion on both sides. Now this is disseminated lymphoma. Now, should we call it a renal lymphoma which has gone to these sites, or is it a part of nodal lymphoma which has also involved kidneys? Thoughts? May I ask the opening batsman, sir, your thoughts? No, sir, opening batsman, you. Your thoughts.
6-year-old.
60.
60.
60.
Oh, sorry, I was
Sorry,
thinking
my
it's a
bad.
6-year-old. So I think this we will have to take it as primary renal with multiple extra,
Multiple extranodal
because that looks like the focus.
Right. Dr. Padmaj.
I would agree with that. The major disease bulk is in the kidney, and that's how we probably would like to call
Right.
it as.
I also let me involve, yeah, please. Right. So I understand your point, but till date we have not agreed on the SUV level cutoff to decide primary. it is very well seen that the primary can be very small, even in lymphoma. It can have a SUV uptake, which is different from the metastatic site. So that, as of now, is not a criteria. We have other faculty member here. I can see Dr. Mir, Dr. Nihar, Fahima. Let us discuss. I mean, there is no right answer. Let me be very clear. I am equally confused.
If we can go the other way, that nodal lymphomas are common, and then there is secondary involvement of kidney.
Okay. Okay, fine. So now we have two. Score is 2 each. So 2 goal versus 2 goal. I think tiebreaker Nihar.
So common, and then maybe the kidneys involved in the extranodal side. So
Okay.
that was my
Two of my seniors from my AIMS days, Dr. Madam and Sir, Dr. Pravas, what do you think? Kidney going out or lymphoma from lymph node coming to kidney? Primary kidney. So now we have 3 goals each, Madam. Any tie break?
Go more with a lymphoma involving the kidney rather, because it's a primary kidney lymphoma is so rare.
Is rare. Okay, so I think you can we can see that the whole, even experienced oncologists are still divided, and that shows. Yes, sir.
The concentration rate as such between think of the lymphoma state coming dividing there and the lymphoma being the greater. You need to take the rate of coming back.
Yes, sir.
And from that you get sense of that because of what
The point, your point is well taken. The question is, how will you know proliferation rate at all the sites? Now, this patient has 3 lymph nodes, 2 ribs, and 1 kidney. So this remains an issue, always an issue. It is taken that we presume that radiologically the sites which are visible, if there is a diagnosis, histopathological diagnosis from one site, we presume that those sites are metastatic. We cannot go up to hit all the target lesions which are visible. So I have taken your point. The problem is both of these viewpoints, because I reviewed about this, are correct, and we will see how. And this remains a problem with extranodal lymphoma. And again, it is slightly sentimental from which angle, which perspective, which group of scientists do you identify yourself with. There is no doubt, if you see these images, this is only a cut section. If you see whole kidney in this patient, that's involved. So it's very much clear. It looks like complete kidney is the primary organ, because the patient also presented with the abdominal pain and symptoms related to that. There were no chest symptoms. So one would argue that the disease started in abdomen, he developed pain and other symptoms, and there was no symptom in the chest or mediastinum or bone, because they were secondary, came much later. So we will come to this point. Again, similar point. This patient came with this kind of large bronchial obstruction, complete hypoxia, lesion in the bone. We can see discordant contralateral lung involvement. So this is what I wanted to highlight here. Yeah, multiple non-contiguous lesions in the lung. So this is showing exactly what. This is a completely large lung mass, non-contiguous other lobe and other lung, bone, contralateral hilar. Looks like clearly stage 4 lung involvement. Luckily, after imaging, we found a large SOL in the liver, kidney, maybe in the bone, in the vertebra, and elsewhere. So therefore, this is clearly stage 4. But even if we disregard panel C and panel D, panel A and B are in itself sufficient to label this patient as stage 4 lymphoma involving lung. If you have only these sites of involvement, you can clearly say it is a primary pulmonary lymphoma, but stage 4. So this is one example, stereotype example of the situation. Now, before I go to the extranodal discussion, let us see what Lugano has clarified. We always grapple with this issue in our OPD. They have said that the matrix to be considered for lymphoma assessment is the longest diameter of lymph node. And they say a measurable lymph node has to be more than 1.5 centimeter. Sometimes residents come to me in the OPD, sir, this lymph node is 8 mm, but SUV is 7. So suddenly,
so we just have 10 minutes more.
Right. So SUV is 7. So because so what to do? So I think they made our task easy. even if SUV is high, if your target lesion is less than 1.5 centimeter, we can just say it is not a measurable target lesion. You may remain more watchful, but then that cannot be a reason to determine patient is having a refractory disease or residual disease. For extranodal side, it is 1 centimeter. So just a statistical point. And all other sites like skin involvement, GI focus, some other splenic, liver, kidney, they are called non-measured disease. Just either they are present or absent. So coming to B symptom aspects, so B symptom are very much clear. There is no controversy except one, that fever is taken as by Lugano is 101 degree Fahrenheit or 38.3 degrees Celsius, drenching night sweat chills, and weight loss more than 10% over 6 months. Some doubt, some of you have, most of us read NCCN where the cutoff temperature is 38 degrees Celsius. I believe it does not matter. What matters is, are we convinced that this fever is because of disease activity and we have ruled out infection fairly? If your patient is febrile and there is no evidence of infection, it is B symptom. This is a matter of semantic for trial that you take it 33, 38.3 or 38. But then the crux of the matter is, you have to be sure that these night sweats and fever are not because of any incubating infection. The fever, if it is there in lieu of without any infection, is a B symptom. Other symptom for Hodgkin lymphoma, which is important, is fatigue, pruritus. Pruritus is very important for Hodgkin and alcohol-induced pain. It is written that these symptoms may herald a relapse. So therefore, if it is there in a patient, patient of Hodgkin came with a pruritus, then be very careful. If he or she complains of pruritus in future again, anticipate a relapse. I will just show you one matrix regarding B symptoms. So from Indian data, from Dr. Ramesh Nimagada, R-lymph data, nearly 791 DLBCL cases, B symptoms were seen in 38%. Now we maintain a large database of lymphoma at PGI. There are more than 3,000 cases. Our recording of B symptom is 52%. But I would like to tell you why. Because this is only 38% of the patients who completed treatment. And this database of 3,000 has all the patients who were registered. So many patients who have B symptoms, more aggressive disease, they drop out, they die early, they do not complete treatment. So therefore, the real burden of B symptom is fairly high, every 1 in 2 patients. I will also quote the original IPI paper in which 43% of the patient had B symptoms. Internationally, I'm talking of IPI paper. So B symptoms are quite common. Now, extranodal site quickly. So what is accepted is a contiguous involvement of an extranodal site from a nodal mass. This is there. Now, lymphoma can involve any organ, virtually. Lung cancer and lymphoma are 2 tumors which can go anywhere in the body. But the commonest extranodal sites are GIT, skin and head and neck region. Again, second contentious issue is Waldeyer rings, Waldeyer's ring. Waldeyer's ring is this circle of various different tonsil. We always see palatine tonsil, but there are lingual, adenoids, and tubal tonsils. Now, there is again a second controversy, which all of you should agree on this, that we are not clear whether Waldeyer ring is involved to call it E suffix, or just leave it. Ann Arbor is clear. They say Waldeyer ring is a part of lymphoid system. It is not E. It should not be designated as E. But again, extranodal lymphoma study group, IELSG, has a clear viewpoint. They say, we agree that there is a lymphoid tissue in these locations, but whenever there is a tumor, it goes to palate, it goes to parapharyngeal space, it goes to tongue. There is extranodal involvement. So they practice. So you can practice whatever you want, but then be consistent in your data keeping. And whenever you publish that data, always declare which definition you considered. My personal view over, if you ask, is I always designate patient having Waldeyer involvement as E, but I always write the site, whether it is adenoid, base of tongue, or it is a palatine tonsil. Now coming to that primary extranodal, the kidney case we discussed. There are 2 approaches. One is very strict approach and general approach. This is a purist approach, and where they say we can call primary extranodal lymphoma only when the disease is either confined to only one organ, or at the max, the regional draining lymph node, first station, like a breast mass, which is lymphoma, and only axillary lymph node, then we will agree it is primary primary breast lymphoma. Or in that case, if it is a kidney mass with local para-aortic lymph node, this strict approach would probably agree it is that lymphoma. But the general approach, which most of us belong to, it is we go by clinical presentation, maximum bulk of the tumor, and the primary organ, like in that patient of PET-CT, if you remember, the kidney, which is almost completely involved by lymphoma process. So both viewpoints expressed by different speakers here are correct. And most of the previous papers published in last century are with this approach. But now, since we have functional imaging, we can know what is the weightage of tumor in a given case. So therefore, this approach is also gaining some ground. Now, this is again showing involvement with mediastinal lymph node and lung mass. So this will not be stage 4, because if you see, there is only one lesion in the lungs, which is in the lymph node and also going contiguously to a lung mass. This will be stage 1E, and that E will be labeled as lung. Coming to the bulky, not much debate. So for Hodgkin lymphoma, it used to be 10 centimeter. It is still 10 centimeter, the longest diameter, or in old era, 1/3 of the interthoracic diameter on a chest X-ray, almost obsolete in nowadays. For NHL, there is slight confusion. Lugano classification staging system is, there is no clear consensus on bulky disease for DLBCL. They say for NHL, follicular lymphoma, they believe 6 centimeter. For other, they have stopped. They say it is a continuous variable. You just record what is the maximum diameter and stop at it. No need to say whether it is X or not. But NCCN is, is clear and simpler. They say if it is more than 7.5 centimeter, it is bulky disease. So this is, you can always remember. 10 and 7.5. How much time do I have?
4 minutes.
4 minutes. Okay, coming to the last part of staging, then I'll touch upon prognosis briefly. So splenic involvement, how to identify same. Like spleen is highly variable. According to a patient's height, his or her race, body size and habitus, spleen may vary. So if we just take one cutoff that, okay, 10 centimeter is big spleen, it is incorrect. At my height, 10 centimeter may be a normal spleen altogether. So it is said that for splenic involvement on PET-CT, most of us, do it. They have 4 patterns. Number 1 is a homogeneously enlarged spleen, a diffuse infiltration with miliary lesions, which are PET-avid, focal large SOL, which is least controversial, and a large solitary mass in spleen. We will see photographs of these very soon. However, for sake of ease and uniformity, Lugano has said that if your spleen is enlarged without any other explanation, and it is more than 13 centimeter, then you consider a spleen is involved. Now, this is an example. You can see on CT scan alone, it looks just large spleen. There is no lesion, very smooth, clean spleen, no lymph node in this area, perisplenic lymph node also. But on PET imaging, you can see it is diffusely, uniformly avid. And this is showing on PET-CT fuse image, completely homogeneous. There is no SOL, and this is on the coronal section. But this will be taken as splenic involvement by a lymphoma if the patient is of a lymphoma. This is what we often see more in solid tumors, these kind of large SOL. There is no doubt, just for representation, I have shown the difference between 2 kind of lymphoma involvement, here and here. Now, coming to this case, which is no other site, only large, huge, bulky spleen, as if you will find in cirrhosis, portal hypertension. These kind of images you will get in patient with marginal zone, SMZL. And you can see relatively FDG uptake is on the lesser side. Bone marrow uptake is there. You cannot call it a lymphomatous involvement because the bone is completely normal over here, vertebra as well as sternum. So this is primary splenic marginal zone lymphoma patient where the uptake is lesser. Now, bone marrow involvement, this is again a very practical point. Now, should we do bone marrow involvement in the PET era or not? Let us discuss. Now, if a PET-CT is performed, then it is agreed by most lymphoma experts that the bone marrow aspirate and biopsy is no longer required for routine evaluation in Hodgkin lymphoma. It is clear for Hodgkin. What happened for DLBCL? There is an issue. In DLBCL, we always know that the involvement of marrow can be patchy. It can be low grade. It can be here and there few cells, which PET-CT cannot pick up. And the statistics is that around 10 to 20% of cases of involvement of marrow by DLBCL cannot be picked by PET-CT scan.
So we have last 2 minutes.
So what to do? If PET shows bone marrow lesion, then there is no need to do a bone marrow examination. You can do away with it. If PET is negative, then you have to do a bone marrow examination because to pick up this 20% low grade bone marrow infiltration. So by and large, we have liver is similar. Almost whatever we saw in spleen, diffuse involvement, focal lesion, liver is there. Now if you can give me 5 extra.
I think we'll have to skip it and move to the next session.
Okay, so just 2 minutes, I'll just complete GI lymphoma. Now, GI lymphoma, very quickly, I will go, is a Paris. This used to be the original GI lymphoma classification, Paris system. And if you read very carefully, it is almost like solid tumor carcinoma, where lymphoma confined to mucosa, gone to submucosa, gone to subserosa, gone to serosa, almost identical. Now that, this was an era when people always used to do laparotomy for GI lymphoma, and you used to have all the tissue. To identify this, you have to have this tissue. But now most of the diagnosis of lymphoma in GI is through endoscopy or through upper cutaneous biopsy. Therefore, we do not have tissue to know whether it has gone to mucosa or not. So therefore, Paris system is gone. Now what we have an interpretation of Lugano system, which is again similar, very simple, confined to GI tract. Number 2, GI organ, as well as local lymph node versus distant lymph node, penetration to serosa and involving other organs, and stage 4 is disseminated. So this used to be Paris system. You should be just aware that there is something called Paris system, and then Lugano system is again applicable. Cutaneous lymphoma, I'll take just last minute to touch upon it. This is, we know, 3 stages: patch, plaque, nodule. Patch is not elevated. Plaque can be slightly elevated and palpable. This is inflamed plaque, and tumor lesion is more than 1 centimeter in size. So now, very briefly, T1 is when less than 10% of the body surface area. T2 is more than 10% of body surface area. T3 is tumor, and T4 when it is erythroderma. The point I want to tell that in Indian skin color, erythroderma, we always see, Western pictures, white skin people, where erythroderma is clear. So we tend to miss erythroderma. This is how in a colored person erythroderma would look like. We have to be more vigilant. We have to touch and press upon it to see whether it is really inflamed and blanching. So, and apart from node is, one last important point regarding node staging for CTCL. If node is enlarged in CTCL, it does not mean it is involved. You have to do a biopsy. The biopsy can yield dermatopathic lymphadenopathy, which is nothing but change in lymph node because of constant antigenic stimulation because of lymphoma in the body. So therefore, a dermatopathic lymph node is enlarged, but it is not systemic spread of lymphoma. And if it is involved by CTCL, you have to demonstrate Sézary cell or involvement. So this is the single most take home from cutaneous lymphoma. And the B is blood. And it is these kind of cerebriform nuclei is a hallmark for Sézary cells. So B0, B1, B2. B0 is either no Sézary cell in the circulating blood or less than 5%. B1 more than 5%, and B2 is more than 1,000 per microliter Sézary cells.